The evidence pyramid categorises evidence based on robustness. Meta-analyses and systematic reviews sit at the top, followed by randomised controlled trials, while at the bottom we find experts' opinion and case reports. In the middle we have cross-sectional studies, case control studies, and cohort studies. When prescribing exercises and training interventions to improve athletic performance, it should be based on the most relevant and up-to-date scientific evidence. However, S&C research is plagued by poor quality evidence that often informs training. Some of the reasons why articles are low in quality include the authors lack the necessary knowledge of research methods, the resources invested in the research are limited, or for whatever reason, the research was carried out in a hurry. Therefore, to help improve the robustness and the interpretation of S&C research, Marco Beato published an article in the journal Frontiers in Sports and Active Living titled Recommendations for the Design of Randomized Controlled Trials in Strength and Conditioning, Common Design and Data Interpretation. First of all, randomized controlled trials are studies that aim to verify a research hypothesis in which a number of participants, for example athletes, are randomly assigned into groups that correspond to a specific training protocol. An example of a randomized controlled trial is the comparison between a new resistance training method compared to a control group or an active control. A control group is a group of athletes that don't train, whereas an active control group is a group of athletes that undertake best training practice which has been proven to be effective. This presentation, brought to you by Talking Sports Science, will be a summary of Marco's recommendations by talking through 5 key considerations. First of all, it's important to consider the 4 phases of randomized controlled trials. To enhance our research design knowledge, researchers in S&C can learn something from clinical medicine. Clinical trials are classified into 4 different phases based on the objectives of the trial. Phase 1 trials are the first studies that verify the effect of an intervention and are usually carried out involving small samples. Phase 2 trials involve a larger sample, which aim to understand, for instance, the efficacy of an intervention in comparison to a control or the dose-response relationship. Phase 3 trials aim to confirm the efficacy of an intervention using a larger sample. This typically involves collaboration between research groups, while Phase 4 trials are confirmatory or registration trials. Applying this to S&C, if weak evidence exists for a new training method, practitioners should design small sample studies. However, if this training method has already been proven effective, it is not recommended to continue to carry out small studies. Instead, it is recommended future trials should involve larger samples. Next, it's important to consider randomization. As the name implies, participants or athletes should be randomly allocated into groups and not simply selected by the researchers or coaches. Researchers and practitioners can use different types of randomization. There's simple randomization. This approach maintains complete randomness of an individual to a particular group. The most common and basic method of simple randomization is flipping a coin. Computer-generated random numbers can also be used. There's also block randomization, which is designed to randomize individuals into groups that result in equal sample sizes. Blocks are small and balanced with predetermined group assignments, for example, an intervention and control group, which keeps the numbers of participants or athletes in each group similar at all times. And there's also stratified random sampling, which starts off by dividing athletes into groups with similar attributes, for example, strength level, Then a random sample is taken from each group. That's 3 examples of how to randomize athletes into groups. There are other approaches. However, regardless of the approach, when conducting randomized controlled trials, the randomization helps control for bias and confounding factors. Next, a key step to ensure robustness in randomized controlled trials is the selection of a control group or active control. For Phase 1 and 2 studies, a control group should avoid performing any relevant training which could affect the validity of the trial. If researchers do not know the efficacy of a new training method, they need to verify its effect in comparison to a control group. When randomized controlled trials have been successfully performed, researchers could state that this new method is effective. And if enough randomized controlled trials are available, a meta-analysis could be performed. However, in sport, asking athletes not to train is impractical and potentially unethical. Therefore, an active control can be used, which, as seen previously, is where a group of athletes carry on training using proven and effective training methods, and their results are compared to a new training method or intervention. In randomized controlled trials, there are a few common mistakes to be aware of. There are 2 types of errors in research. A type 1 error is when a training method is found effective when it is actually ineffective. This is also known as a false positive. Whereas a type 2 error is when a training method is found ineffective when it is effective. This is also known as a false negative. When it comes to sample size, size matters. This is because small samples increase the chance of making a type 2 error, as underpowered studies may struggle to find differences between interventions or a control group. Therefore, the evidence may be misinterpreted and lead to inappropriate training decisions. And they could also be a waste of time and money for both researchers and athletes. We have just talked about type 2 error, which is an issue. However, it is more problematic to design intervention studies using an unsuitable alpha level, which can lead to the claim that an intervention is effective when it is not, i.e. a type 1 error. In S&C research, the most common alpha level, also known as significance level, is 5%, i.e. a p-value equal to 0.05. which put simply means there's a 5% chance of a type 1 error. The alpha level therefore defines the boundaries for determining the critical region that leads to significant results. Confidence intervals are related to the selection of the alpha value. An alpha value of 5% corresponds to 95% confidence intervals. Practitioners should be aware of the differences of using either 95 or 90% confidence intervals. Using 90% confidence intervals is possible, but this decision should be justified because using it increases the risk of type 1 error. And last but not least, some other considerations we need to be aware of. A common statistical error is concluding that an intervention is successful if there is a significant within-group difference in the experimental group but not in the control group. For statistically sound randomized controlled trials, the experimental and control groups must be directly compared. Also, p-values are often used to provide a definitive yes or no answer in the decision-making process. However, it is recommended that researchers also consider the effect sizes and confidence intervals. This is because confidence intervals provides critical information beyond statistical significance. For example, they provide a plausible range of values for the true effect and reveal the precision of the estimate. And that concludes some of the things you need to consider when conducting randomized controlled trials. Hopefully this will increase the robustness of future S&C studies, and that you found the information useful in terms of interpreting and critiquing S&C research. Thanks for listening, folks. See you next time.